So, good morning, dear chair, dear colleagues. My name is Dániel, and let me introduce you my PhD thesis title, which is New Horizons for the Treatment of Urachal Cancer. I'm a sixth-year medical student, also a first-year MD PhD student at the Department of Urology. My supervisor is Tibor Szarvas. My SMS is Isabel Amorim, and my vision would be to innovate treatment options for urachal cancer. And my mission is to provide a comprehensive overview of urachal cancer treatment experiences is the mission to get there. We've discussed two specific goals for the start of my thesis. One would be a project discussing the systemic treatments of urachal cancer, and then the second one would be discussing the combination of a surgical and the chemotherapy treatment for advanced stage metastatic urachal cancer. So my first project is titled Comparing the Efficacy of Different Systemic Therapies of Urachal Cancer. It is a systematic review and meta-analysis. So what is urachal cancer? It is a malignancy originating from the embryonal remnant known as the urachus. It is a rather rare disease, only accounting for less than 1% of all bladder cancers. But it is rather aggressive, with only a 51% overall survival for 5 years in general for the disease. Unfortunately, the symptoms are non-specific and late, and therefore the disease is usually discovered at a much progressed stages. And for these advanced stages, the survival is even worse. It is 38% for the overall survival of 5 years, and the regression-free survival is even less. It is 28%. So here we can see what the problem is with this disease. Unfortunately, surgery is the gold standard for early treatment, but in advanced stages there is no consensus or guideline on the treatments. The two most frequent drugs used are fluorouracil and cisplatin, but these are not based on any evidence, but rather for the location of the cancer, which is the bladder, and cisplatin is used for bladder cancers, which is effective there. And for the histology, fluorouracil is used for colorectal cancers, which urachal cancer resembles colorectal cancer on histologic samples, and that's why the choice was made. The outcome we would like to address is radiographic response, which is a criteria score based on radiographic progression or regression of the disease. It is a strict system, and it is evaluated right after the treatment. So usually it is the one reported, and the patients aren't lost to follow-up. Our aim would be to compare the efficacy of different treatment strategies to find the best alternative for the highest patient survival. So we framed our question in a way that which of the most commonly used treatments is the most effective. And we use the PICO framework, with patients being the patients in advanced urachal cancer. We would like to compare the different systemic treatments with each other. And as I've mentioned, the outcome we would first like to look at is radiographic response and other types of survival as well, if we can find them in the literature. And if enough survival is reported, then we will include it as well. Our hypothesis is that systemic treatments vary in efficacy. So why is it important in a clinical picture? We would like to give the optimal treatment to patients with urachal cancer. Here you can see our final search key, which consisted of one domain. It is for the patients or the population domain. This search key is in this way because we used it in all of our projects, or both of our projects. Here you can see the number of hits, a little bit north of 3,000. And I've highlighted 3 key articles that I've found to be really useful. Here you can see these key articles side by side. And as you can see, the population and the outcome is the same, but treatments vary a little bit from article to article, but after discussion with our statisticians, the project is feasible. Here you can see our flowchart selection. After the title and abstract selection, we have a little bit less than 200 articles, and we already started the full text selection as well. Here you can see our progress, which we've made so far with this project. And our second project would be investigating the safety and efficacy of surgery combined with chemotherapy in metastatic urachal cancer, which would also be systematic review and meta-analysis. For the background, it's partly the same. although there is a group with a lot worse prognosis, probably one of the worst prognoses for this disease is the peritoneal metastatic patient subgroup in this disease. As you can see, the survival is less than 20% for 5 years in this group. So it is a really important part of our research to find a solution for these patients as well. There's a new treatment rising, which is CRS with HIPEC, which is already used in other fields such as gynecology or gastroenterology, achieving great results, less than or more than 50% survival. And we would like to see if this treatment is or could be useful in this disease as well. We would like to investigate the overall survival following cytoreductive surgery with hyperthermic intraperitoneal chemotherapy in patients with peritoneal metastatic urachal cancer. So we frame the question in a way that how long is the survival of patients or peritoneal metastatic urachal cancer patients in CRS with HIPEC. This would be a descriptive study because unfortunately we couldn't find comparator groups in the literature for this specific subgroup of patients, and therefore we had to frame our question around this. And our hypothesis is that CRS with HIPEC in peritoneal metastatic urachal cancer patients may reach similar rates in survival as non-metastatic patients, which is a clinically really significant goal if you think about it, because for the metastasis, it is a lot worse prognosis, and then we can reach the same as non-metastatic patients, then this would be a huge success for us. And the clinical research implication is the same as for the other project, to give the optimal treatment to patients with urachal cancer. So the preliminary search is the same, with the same search key. We conducted it in the same 3 databases, and I found 3 key articles that could be useful for us. For the preliminary search, there is one previous meta-analysis for this topic, but it doesn't focus specifically on this treatment group or this treatment, and it was conducted 8 years ago. And on the Prospero, there is no registration so far. Our topic so far is only feasible, but the Prospero is not yet started. So in summary, we would like to finish 2 projects. The first one with the systemic treatments in the autumn of next year. And for the second project, we would like to finish that in the spring of the year after that. And hopefully we can keep this schedule, maybe even speed it up a little bit. I would like to end my presentation with a quote from Johann Wolfgang von Goethe: "Doubt can only be removed by action." Thank you for your attention.
So in the first project, the population looks quite wide. Do you plan to use subgroups?
Thank you for your question. And yes, it is quite a heterogeneous population if we look at it. And we did have a discussion with our SMSs and statisticians about this. And if we have enough data, we would like to subgroup the patients by line of treatment and by TNM stage as well. And if we have enough data for that, maybe age as well. Thank you.
Hello. It was a great presentation. Thank you. I have a question about the second project. Are there any data about adverse events, maybe, about the treatments in the articles? Or do you plan to talk about any of these adverse events in your paper?
Thank you for the question. And yes, there are actually. It is quite often reported in our articles as well about the adverse events. And this is why we titled the project as well as Safety and Efficacy. So we would like to, I guess, make a table based on the adverse events and their rate of happening. And we would like to also include that in our article.
Thank you.
Thank you.
Regarding the second topic, I'm not really familiar with the urological oncology, but the second topic is you told that it's not easy to have a control group because you don't really have any. What do you think? Is it wise to compare 2 different groups of patients? I mean, two groups which are, the one is metastatic disease, the other one is non-metastatic disease, and the treatment is different as well. So is there any role to playing any important role, the surgery in the first group, I mean the non-metastatic group, or is just the medical treatment, the oncological treatment? So to compare the two groups is probably it's not easy.
Yeah, thank you for the question, firstly. And yes, it is unfortunately a recurring problem in our projects that is quite difficult to compare different, I guess, subpopulations in our population. Yes, we did discuss it widely. We chose to present it this way because there is, I guess, a research group in the Netherlands that they are using this technique quite often, and they are achieving quite good results. Our first and main key articles from them as well. And they decided to report it based on this comparison with the non-metastatic patients. So that's why we thought about using the same method here. And yes, we would like to account for as many confounding factors as we can. But yes, it is a limitation for our study there. And yes, for the surgery, it does play a huge part in, I guess, both patient groups. For the earlier stages, surgery by itself is the gold standard treatment. So it is, yes, it is a limitation. It is difficult to compare, but we'd like to do our best.